Just to continue, as you can imagine, the pain is significant with fractures, so patients usually require opioid narcotics, often IV pain medication. We may supplement that with some Tylenol. They're going to be on muscle relaxants, and those are very important to give to kind of keep that cramping and from where the break has caused the muscles to be very hypersensitive, to calm that down. If you have an open fracture, the patient will always typically be put on antibiotics, and you'll need to evaluate when have they had a tetanus injection in the last few years, and usually they'll go ahead and give one of those if they haven't had it in, say, the last 5 years. As we know, most patients that are immobile are going to be on anticoagulants, like typically Lovenox or heparin sub-Q injections, because these patients are at high risk for developing DVTs. NSAIDs are usually avoided with the fracture patient, and then because of immobility, lots of pain medication, and often sometimes low appetite levels, patients do get significantly constipated and require stool softeners. In the picture there, you can kind of see what we call skin traction. It's where you have a kind of an immobilizing device put around one of the legs. If you have, for example, a leg fracture, or sometimes a hip fracture, but usually you see this mostly with femur fractures, and they will, put your leg in this little apparatus that usually goes up to right below the knee, and it velcros around. It's got kind of like a foam type cushiony part that goes up against the actual skin and the foot, and then at the bottom of the foot you can kind of see that there is a little piece of rope that's attached to a metal piece, and that goes up through that little pulley that's been added to the foot of the bed. And on the bottom, although you can't see it very good, at the end of that rope, but not touching the floor, is usually a 5-pound weight that is applied. And that's the usual weight. The reason that we would put someone in this type of skin traction is that it is pulling the bone in a way so that the two ends of the fracture are not jammed up against each other, and that the leg, the bones are not displaced. And so then it's kind of aligned in a way to allow it to be in alignment. That's going to help the pain situation. That's going to decrease muscle spasms when you have that. And because the main goal, the primary objective for managing fractures is to get the bone in proper alignment. And so that's what's got to take place first. Sometimes someone might be in this and they see how they do, or this might be a temporary measure until the person can be taken to surgery for a full surgical repair. Now, it's pretty important that the weight has got to stay off the floor, and you can kind of see this while this is attached. Imagine how many patients they slide down in the bed and their heel then is against the foot of the bed. At that point, the weight is not having the pulling pressure that it normally would, and so you may find your patient down at the foot of the bed pushed up against that, and telling you that they're in severe pain again. And so then we have to kind of take care as a team to kind of hold that weight, get a couple people to pull them back up in the bed, and have that skin then have the traction really reapplied to kind of help keep that bone in alignment. And another thing, if the weight is on the floor, it's not doing anything because it's not exerting the weight pulling on that. And you have to be cautious going around the foot of the bed to make sure that you don't hit that weight, because if you knock the weight off of there kind of in a quick manner, imagine the recoil that's going to occur, and the patient's going to be in significant pain from that type of an event as well. So we're going to explore some of this in terms of what are some of the biggest risks and things that you may see with fracture activity, and kind of what is important to know, the key things to know in terms of medical surgical treatment and be prepared for. First off, here's an example of an immobilization device. Sometimes if you have a fracture in the wrist or the radius or ulna, you will have this applied first. And sometimes that's done because it's like, say it's a hairline fracture. They might not even need a cast. They may just need this for a while. But often when they have injuries like this, there's a lot of swelling because your arms tend to be in a dependent mode when you're up and moving. And so until they have the swelling kind of come and go, it's kind of nice to have a nice device put on there that can hold pressure and keep the bones in alignment, but they may wait a few days till some of that swelling goes down until they do surgery, or they may wait a few days till the swelling goes down and then put a cast on, because if you have too much swelling and then you put a cast on and then the swelling goes down, you don't have a good firm splint, because on the inside then it's loose in the cast. So just kind of think about it that way. This is the most common type of cast that we see these days, is a fiberglass synthetic cast. These usually dry like within about an hour at max. So they're nice, but you can imagine if you did have swelling and this was put on immediately, you may get more swelling as the injury kind of progresses. And then you've really got a cast that's way too tight that can cause some problems with sensation and skin issues, as well as actual pulses be weakened and things as well. So things you have to pay close attention to. This is just some information. You want to always, in patient education, tell the patient to avoid inserting sharp objects under the cast. You'd be surprised how many people that these type of casts will just make them itch like crazy. And people will take knitting needles and all different kinds of things down inside there, and they're just asking for some type of skin irritation and infection can easily come about from that kind of thing. As I said, most casts are like going to dry with just in a few minutes. There are some special waterproof type that athletes sometimes can get. You don't see plaster casts very often, but just in case somebody ever does, those take about 24 hours to dry. And then you may have what's called a cast window on a cast, particularly whenever there's been a open wound that needs to be like treated or dressed or just observed to see how it's progressing. That's a feature for a cast window. Here's an example of an arm where somebody's had a cast and it was likely too tightly applied, caused skin irritation, and or the patient caused it from scratching. So just know that's kind of what you can see. You want to inspect the skin at the edges of the cast as much as you can see. Tell the patient to report any drainage, odor, pain. Plaster casts can have like little bitty crumbs that cause little hard areas that can irritate the skin as well. And the patient may want to put a lot of cream or lotion under there because it is itching. You need to tell them not to do that because, again, it can macerate the skin and it can also be a breeding ground for bacteria to grow. Lots of other types of casts, have really limited mobility, so you want to make sure that you're turning your patient frequently from a comfort standpoint, but also to prevent skin breakdown in other areas, and to kind of promote respiratory, not getting atelectasis and different things like that as well. Some patients can have full body casts, and toileting is kind of a crazy issue with that to kind of work around. And some of those type of casts can cause some abdominal discomfort, And just be thinking about typically, as early, as you work with physical therapy and with the physician on mobilization and what's going to be allowed, and usually you're going to have specific orders that tell you what you can and can't do in terms of mobility. In terms of preventing neurovascular complications, you want to perform neurovascular checks every hour for at least the first 24 hours after a cast is applied. If the patient should go home with a cast, teach them how to do that, and so they know what to call the doctor for if there's problems. We would be notifying a MD of any changes in color, pulse, alterations in sensation, or motion. What if a cast is too loose and they're able to move around in it? And try first, trying to have the patient, realign, like just change their position in the bed or the way they're holding their arm or their leg in the cast, and then reevaluate in a few minutes and see if that has alleviated any of the sensation or pulse issues, because occasionally it can be they've been laying on the cast for a certain way too long because they don't want to move. So sometimes it may not. You want to evaluate if it's a true neurovascular issue or not. Elevating the affected extremity on pillows for 24 to 48 hours helps decrease swelling. And you want to avoid dependent positioning for long periods of time also. This is more big traction that you see that usually is considered balanced suspension skeletal traction. And this is a condition where they actually will have a pin through the skin that the traction is connected to. And you may see patients with these big overhead trapeze type apparatus, so that gives them the ability to use their arms to help raise themselves around and move around in the bed a little bit better. And again, you see the weights on this is usually a little bit more hefty than just the skin traction. Here's some more pictures of it, and you can see what it looks like there at the foot of the bed. Different types depending on what brand that they use. Here's one that's got an actual external fixation device that's got pins through the joint where the metal apparatus itself is holding the bone apart so that it has the ability to heal in between. And those pins have to have pin care around them in a very sterile procedure, usually twice a day or as ordered by the physician, just to make sure that those insertion sites on each side are covered, but in between get some very good cleaning care with, sometimes you'll see betadine used or different things to clean right around the pin sites. This is just a little slide about traction care. Patients in traction may have urinary retention because they really don't want to have to get on and off the bedpan. So, it's important to try to encourage movement and also, again, keep the traction in line properly. Complications of fractures, patients can go in shock. They can develop a fat embolism syndrome. They can have a venous thromboembolism. They can develop infections, compartment syndrome. They can have chronic complications because the bone never really does get enough blood supply, so it becomes ischemic and can become necrotic and the bone actually die. You can have delayed bone healing. They can sometimes have permanent peripheral neurovascular dysfunction, where muscles or nerves had to be cut through to do repairs, and so they never have the right sensation again after that. Obviously pain, physical immobility, and often inadequate nutrition. And this is just to give you an idea of a bone marrow. You see it's got some yellow fatty material in it. That's what causes fat emboli.